Welcome to the UCSF Sports Medicine Podcast, 6 to 8 weeks, Perspectives in Medicine. During our program, we continue to cover a variety of hot topics in the sports medicine world and more.
All right, welcome everyone to our UCSF Sports Medicine Podcast, 6 to 8 weeks, Perspectives on Sports Medicine with myself, Dr. Nirav Pandya, Dr. Brian Feely, and Dr. Drew Lansdowne. Today, we're going to be talking about osteochondral lesions or OCD lesions. These are injuries that basically we see both in kids who develop them genetically as well as in adults who may have suffered a traumatic injury. The reason why it's important to recognize these injuries is that a lot of times they will get missed on x-rays or sometimes will have very non-specific symptoms and patients will come in with years of pain. It's important to understand that this involves both the bone and the cartilage and the various different treatment options that are available based on how stable the lesion is, your age, and how big the actual defect is. We can see these in the knee, we can see them in the elbow, we can see them in the ankle, as well as less commonly in the shoulder and the hip. So join us today as we talk about these injuries to these various joints, and check us out at 6to8weekspodcast.com.
So Nirav, I'm going to ask you the first question. What exactly is an OCD lesion? And do we know why they form?
Yeah, so that's a great question. So a lot of people will come to the office and see on their MRI report, oh, you have an OCD lesion. They're like, what's going on? Like, why? What does this mean? And the way I like to break it down to patients is the O is osteo and C is chondral. And D can mean various different things. It can be defect, it can be dissecans, but in general, there's an injury to cartilage and bone. And I think that's important. It's not just the cartilage, there's bone involvement as well too. And it's area that's weaker. And sometimes it can be weak enough where that piece of bone and cartilage is actually coming off or is about to come off. Sometimes it's just weaker and it's still relatively fused to the underlying structure. So basically an injury to cartilage and bone, and it can happen for one of two reasons. One, we think that some kids are predisposed genetically to have it. And what's happening is there's decreased blood flow to that particular area. And there's some areas we commonly see that'll have this that makes that area more susceptible. And then you take a kid who is active and doing sporting activity, and you have this susceptible area then become symptomatic. And a lot of this is still, there's a lot of basic science work being done about that. But that's kind of the more pediatric population. And the adult population, and I'm sure Drew can answer this as well too, is a lot of times it happens from a traumatic injury. Your kneecap dislocates, and then a chunk of cartilage and bone comes off. You tear your ACL, you have a big, kind of a bone and cartilage injury. So I kind of say they're both related to activity. Some develop from the trauma itself, some are there, and then the trauma or overactivity will cause it to happen.
Yeah, now, as you alluded to, you see a lot of these, Nirav, in a adolescent pediatric population. Drew, do you see these in adults? And if so, what sort of symptoms tip you off that this might be what's happening when a patient comes in?
Yeah, we do see these in adults, and I think sometimes it can probably happen from that traumatic injury, and then other times it can probably be like a juvenile form that was kind of okay, and then eventually was just weak, like Nirav said, and then failed, later in life rather than early on. So it was like maybe they're doing fine, and then eventually just fell apart. And it's the type of thing that usually causes pain, and then swelling is the big tip off. And that's like activity related swelling. So like I go for a walk, a hike, a bike, and my knee blows up every time. There are times where like that piece of bone and cartilage falls off or becomes loose in the knee. And that is often like, my knee was kind of achy, not great. And then I stood up and I felt a pop, and then I couldn't straighten my knee out, or I stepped off the curb. It could be like this low level thing that really shouldn't cause an injury, but that key of feeling a pop and then the motion being restricted. And that can, line up with that loose piece being stuck in the joint and not letting the knee move normally.
Yeah, my patient with the largest one of these was exactly like that. He said he was skiing. He went off what he called the smallest jump at North Star. It landed, and then he couldn't get his leg straight. And it was a 3 by 2 centimeter osteochondral defect that had come loose. And when you ask him, he said, for the last couple of years, if he really skied hard, his knee would swell a little bit. He would sometimes feel like there was something moving a little bit in the knee, and then it was a very innocuous injury. So, Drew, when these patients come in, what imaging do you recommend that they get, and why do we get them?
So we'll always start with x-rays. One of the reasons is just that we can get them quickly and right away. They're cheap, they're easy. But then if you do have that loose piece of bone, you can often see that on x-ray. There are times where the bone hasn't moved, like it's still totally attached, but there are findings that can tell you, that this is like what their symptoms are from. So the appearance of that area of the femur can be different. It can be more lucent, so like not as bright on X-ray. So even if like, oh, it's soft tissue, it's cartilage, but the X-ray can often pick it up. So we'll definitely start there, and then next step is usually an MRI, because that'll show three-dimensionally the soft tissue as well, and better localize where it is, if it's loose, what it looks like, everything like that.
All right, Nirav, Drew and I both talked about these in the knee. What about in kids? What area of the body are these most common, and who are the athletes that you typically see these in?
Yeah, and I still think number one, the knee, the medial part of the knee is the most common. We'll see it in, and these are kids who, they're running, they're jumping. We see them at a young age. I think we kind of see it in a similar group of young, active, healthy kids. The other two areas that I think are unique, the one area I think that's particularly unique to kids is the elbow. Particularly with pitchers and gymnasts, they'll develop them on kind of the outside part of the elbow. We call it technically anatomically the capitellum. And it's just the stress that these athletes are putting across their elbow. From repetitive throwing, you have something called valgus, which basically impacts the outside part of the elbow. So, and the same thing with gymnasts, they're constantly loading their elbows and putting force on the outside part of it. So you have an area that's weaker, the cartilage or bone's weaker on that side, and then you're doing something with your arms that the body wasn't designed to do, throwing fastballs 90 miles an hour repetitively, or doing 25 hours of gymnastics, and that cartilage and bone will break down. So I think unique to that population, you'll see a lot of elbow issues, particularly on the outside in kids. And we also see it in the ankle as well, too. I think the ankle is a great example of how it can happen both traumatically and atraumatically. A lot of times when someone has a bad ankle sprain, you can see these happen on the outside part of the talus, which is one of the bones in the ankle joint. And then if it happens more on the inside, those are ones that sometimes are more kind of the genetic ones that develop over a period of time. I think the key thing is that in general, we have a lot of treatment options for the knee. They can do relatively well. The elbow in general do pretty well, particularly if you're going to change activities. I think the data for ankle OCDs is pretty poor. I still don't think we have a good grasp on how we can treat those appropriately. They're rare. But a lot of times patients struggle with them just because of the amount of force that goes across the ankle joint, both from loading it as well as kind of the rotational forces. But yeah, I think anytime a kid comes in, they're having discomfort in those areas, it's been going on for a long period of time, I think it's appropriate to get the x-ray, because that could be their source of pain, and it's not necessarily quote unquote growing pains, which a lot of times what kids with this problem get diagnosed with and keep going on for years without knowing that it's there.
Yeah, I really hadn't thought of that. That is one of those times where we say it's probably just an ache because you were active and you're growing, and really we have to take those a little bit more seriously. So Nirav, when and how do you treat these without surgery in a pediatric population?
Yeah, I think the key really comes down to, in with an MRI, is this quote unquote stable or unstable? And, essentially what I describe to parents is like, is this piece going to fall off pretty soon, or is it something that's there, but you're not worried about it coming off? And the way you see that in MRI is you're seeing if fluid is actually behind the area that's affected. And the way I tell parents is that it's almost like a crack in the door. If there's fluid able to get behind it, then we know that there's a risk that it's going to fall off, as opposed to if you've got fluid, it's not going behind it, there's more likelihood that area may heal. In general, if the more skeletally immature you are, meaning that your growth plates are more open, and that lesion's stable, then I pretty much will trial a lot of these kids with non-operative management. In the past, they'd cast people, and that didn't really show to do very well. So usually what I'll do is I'll have these kids still be able to walk around, do their day-to-day stuff, but I'll brace them with a particular kind of brace that will help, in the knee, offload the area, get them into physical therapy, and kind of keep them out of sports for 3 months. And then typically then you repeat imaging to see if they're healing. For most stable lesions, if you catch them early, they have a pretty good chance of healing well. Sometimes what may happen if you have a stable lesion, it either doesn't heal or they still have pain. And that's where you go down the operative route, which, obviously we'll talk about a little bit later.
So we all have children in the kind of, I would say, OCD central range from 9 to 12. Where are the good OCD lesions to have that you think are more likely to be able to be treated non-operatively versus the ones that maybe are more likely to need surgery?
I would say, a lot of it's size. I think the smaller lesions will do better. I think ones in the knee that are in kind of the atypical areas do relatively well. So, your trochlea, your patella, the ones on the medial part of the knee where we just load a lot, those are the ones that are most common. But because we're loading them a lot, they have a tendency not to do very well. So I think if you have atypical ones that are not necessarily in high stress regions, they have a tendency to do very well just because you're not stressing it. When they're in that medial part of the knee, it's harder for them to heal. And also, as much as we talk about non-operative treatment, kids are going to do their stuff even if they have pain. So you can brace them, you can do things, but they want to be active. And a lot of families will say, look, do we want to go down this route of 6 to 9 months of non-operative management and then come to 6 to 9 months later and then realize that we need surgery anyway, and then it's another 6 months of recovery? Or do we go ahead and fix this up front? And I think that decision for like maybe a 12, 13-year-old probably makes a little bit more sense to maybe be a little bit more aggressive in terms of fixing it, as opposed to like a 6, 7, or 8-year-old who sometimes will catch those on and will say, look, you have a very likelihood you're going to heal. Let's not go through the surgery. So I think age also comes into consideration as well too.
Yeah, totally. So Drew, for surgery, we talk about doing a repair, putting what's injured back on, or replacing and doing some sort of cartilage reconstruction. What are your indications about when you think about repairing these in the knee?
To be able to repair, we usually want to have some bone on the piece. So sometimes you can get just a pure chondral injury where it's just the cartilage and that healing capacity isn't as good. So we may not be able to fix that. There's some times where that can still be fixable, but I think more unusual. And then if there's bone on the back, the cartilage is healthy, sometimes those can be fixed. The hard part is a lot of these lesions, that bone isn't normal. The underlying bone may not be normal. So then you're just kind of putting back bad bone into an area. And, that's where, like, if they're a lot younger, that healing potential is going to be so much higher. If they're an adult with this like unhealthy bone that's remodeled already, the chance of getting that to heal, I think, is really unlikely. But so we're trying to make sure that we're putting, a healthy, viable piece back to something that it can heal to, and that you can expect, after going through that rehab and recovery, that you're going to have a good outcome.
So, Nirav, is it the same for you? Do you basically look for that sliver of bone, or in kids, do you think it's a little bit more amenable if you have just cartilage?
I think with kids, there's just because in general they have a little bit more healing potential. I think the outcomes of fixing cartilage-based pieces, particularly if you get to them early, within 2 weeks, is a little bit higher. A lot of times I think that if yes, you can get a kid who's just cartilage and they've got more healing potential, but then the piece is swollen, it's kind of just a dead material. And even if you are like 6 to 8 weeks out, it's not worth to try to fix it. So I think a lot of it is what the piece looks like, what their age is and how long it's been floating around there. But I still do think that bone is really key. A lot of the techniques for fixing cartilage-based pieces are so invasive and open, and you're putting all this material in. And, is it with all the cartilage restoration options, is it better to do something that's going to be more definitive than have them, try to fix this piece, they go back to activity, and then it falls off and they have a worse looking knee. So yeah, I think a lot of it is based on, what that piece looks like when you're in there.
Yeah, I mean, largely for us in the adult world, that bone looks pretty bad. And oftentimes we're talking about doing a reconstruction, even as a primary case, or at least warning the patients we're going to have everything available. Drew, what is your thought process when you're thinking about how you're going to go about doing a cartilage reconstruction? We have different options. There's microfracture versus putting new cartilage and bone, either with your own tissue or cadaver, or some cartilage transplantation with MACI. What are your thoughts on how you divide those out for a patient?
For like a true OCD lesion where it's that bone and cartilage that's missing, I will usually default to using like bone and cartilage to reconstruct it. So that being either an osteochondral autograft or allograft, where we're taking a piece that has bone and cartilage, because oftentimes the problem, it's not just that you're missing cartilage, is that bone around it is also unhealthy. So doing something that just replaces part of it, I think, may be an incomplete solution, and the osteochondral treatments can work really well. And so, yeah, osteochondral autograft, osteochondral allograft, and then those really depend on the size of it. If it's smaller than 10 millimeters, the autograft can work well. If it's 2.5 centimeters in diameter, I think the allograft is going to be the better option.
What about you, Nirav? Same thing for kids, or do you err a little bit more on your own or cadaver tissue?
I try to err a little bit more on their own, but the issue I think that becomes difficult is that when you're harvesting, you can end up near the growth plate. So it does add a little bit of complexity in terms of, am I taking this piece? Where am I intraoperatively? But I do find that, the general, where the allografts, typically come in is it's just so large. There's like the 16, 17, 18-year-old where you're not worried about the growth plates. I feel that in general, for some of the younger kids, usually it's an isolated defect that's relatively small. So you can kind of take it from the notch or take it away from there. And their healing potential is just so well. So I try to use autograft on them. But I agree, if it gets bigger and bigger, which is usually the kids who are done growing anyway, then you go to an allograft. I think it's just very predictable. You're not worried about, oh, geez, like, do I have enough places where I can get enough autograft for? And so, I think allograft is definitely a good choice for those bigger lesions, even if they're younger.
Nirav, do you want to wrap up?
Oh, sorry. Yeah, sorry. The awkward pause. So I didn't see that. Yeah. I just saw Drew's surgery. Mike can edit that out. So osteochondral lesions of the, of the various joints of the body. It's a problem that you definitely need to have a low threshold to look out for. If you're an adult or a kid, you've had symptoms for a while, but it hasn't necessarily stopped you from doing activity, but things are getting progressively worse. Contact your physician, get some imaging. And if it's there, then there are various different treatment options. The goal obviously is to try to get your own tissue to heal to itself, but sometimes that tissue may not necessarily be the best quality. And then we've got various options to basically help to heal you. A very complex area with a lot of options that can be very confusing on the internet, but the key is get you a good solid joint that'll last you for a long period of time. So thank you again for listening to our podcast, 6 to 8 Weeks. You can check us out at 6to8weekspodcast.com, Spotify, Apple Podcasts, Amazon, wherever you listen to your podcasts. Subscribe to us, download your podcasts, and we look forward to hearing us, having you listen to us on our next episode. Thank you.
Thanks for listening to the UCSF Sports Medicine Podcast, 6 to 8 Weeks, Perspectives in Medicine. What do you think of this topic? Connect with us now. In addition to finding our contact form, you'll also find our social media links and our entire 6 to 8 Weeks episode archive. Help us grow our listenership by liking, subscribing, and sharing everywhere. We're eager to hear from you, and we'll be sending you more great thought-provoking content in less than 6 to 8 weeks.